Malaria is a disease that, without adequate preventative measures, can cause severe illness and death. Nearly all of these deaths are among children under 5 years of age living in sub-Saharan Africa. In many areas, most childhood malaria deaths occur during the rainy season. Chemoprevention, which is the use of medicines to prevent malaria, is known to be a generally safe, effective and cost-effective strategy for targeting those most vulnerable to malaria in endemic settings. Seasonal malaria chemoprevention, or SMC, is the intermittent administration of anti-malarial medicine to prevent illness during the period of the year of greatest malaria risk. While WHO has recommended this malaria prevention strategy since 2012 and it was implemented in 13 countries in sub-Saharan Africa in 2020, SMC has yet to reach its full potential in preventing disease and death.
Understanding and addressing the limitations to the rollout of SMC is essential if we're to protect the most vulnerable populations during the time of greatest risk.
The initial WHO recommendation was for doses of sulfadoxine pyrimethamine, or SP, plus amodiaquine, or AQ, to be given at monthly intervals to children less than 6 years during each transmission season, and specifically in the Sahel sub-region of Africa.
Over the past decade, it's become clear that the initial seasonal malaria chemoprevention recommendation was unnecessarily limiting. Growing operational experience showed that we needed to adapt the recommendation to allow for additional cycles of SMC, to extend to other regions with seasonal malaria, and to expand to other age groups which have shown potential benefits from this strategy.
In 2020, WHO convened a guideline development group to consider the latest evidence for all forms of malaria chemoprevention. It's become clear that other areas beyond the Sahel sub-region have marked seasonal variation in malaria and could benefit from SMC. It's also become clear that once malaria is well controlled in children under 5 years, a substantial proportion of the remaining burden may fall on children older than 6 years who could benefit from chemoprevention. Based on research findings, WHO's 2012 SMC recommendation was updated. The update specifies that in areas of seasonal malaria transmission, children belonging to age groups at high risk of severe malaria should be given anti-malarial medicines during peak malaria transmission seasons to reduce disease burden. Each cycle of anti-malarial medicines provides protection on average for about 1 month, depending on the drug combination and the setting. The number of treatment cycles of SMC needed to protect a child depends on the length of the malaria season. For example, if the season of risk is 3 months, 3 cycles of medicines which protect for a month each will be needed. The updated recommendation does not specify a maximum number of cycles that can be delivered. National malaria programs can now tailor their SMC strategy to the local malaria epidemiology and to how long the selected drug combination is effective in malaria prevention. This will better ensure that SMC protects children during the full malaria transmission season.
Chemoprevention strategies work. Evidence shows they've been making a difference, and they can work even better if they're customized in each setting to protect the most vulnerable population at their time of greatest risk.
The additional flexibility provided by the updated SMC recommendation, which encourages malaria strategies to suit local conditions, should enhance the impact of SMC. Together with the delivery of other interventions, this can help vulnerable children at risk of seasonal malaria to grow up living healthier lives.